There have been many changes since the 70s that have shaped the nurse's role in administering chemo and supporting patients. The major change early on was the transition from that of nurses mixing chemo to that of pharmacists. Regulatory agencies like NIOSH and OSHA defined chemotherapy as hazardous drugs, and professional organizations became involved, leading to the publication of the joint ASCO and ONS standards of safe handling.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between.
Hello and welcome to the ONS podcast. I'm your host, Darcy Burbage, chair of the ONS 50th Anniversary Committee. Today, we'll be discussing the evolution of cancer treatments from over the past 50 years and how oncology nurses have been part of this journey, from radical surgeries to less invasive techniques, administering chemotherapy to the precision of oral oncolytics, the technological advances in radiation oncology to the innovative transplant and cellular therapies. We'll reflect on the impact on patients and families and discuss how ONS has ensured that no matter how rapidly treatments evolve, oncology nurses are equipped with the knowledge and skills to deliver the highest quality care. This episode is part of our 50th anniversary podcast series, where throughout 2025, we feature episodes exploring ONS's rich history and promising future. Joining us today are 4 experts who will share the evolution of care they have witnessed while working in oncology, along with their thoughts on the future. John Hillson began his oncology nursing career in 1998, working with both radiation and medical oncology patients. He currently works as an NP in head and neck radiation oncology survivorship at Atrium Health. Thank you for joining us today, John.
Yeah, thanks for having me back.
As a former rad-onc nurse myself, we both know that radiation oncology has undergone remarkable transformations over the past 50 years, from external beam to highly sophisticated precision-guided therapies, such as intensity-modulated radiation therapy and stereotactic radiosurgery. John, how has oncology nursing practice adapted to meet the complex needs of these patients in regards to education, treatment delivery, and symptom management?
Well, I think it's important to look where radiation oncology was 50 years ago. I mean, the first radiation therapy was back in 1896. We are a time-honored modality, but there have been massive changes in my lifetime. In the 1970s, they were called therapeutic radiologists. Their training might have just been in general radiology. Technology was massively changing. The first CT, the first MRI, and the first PET scan for human use all happened in the 1970s. So the very first time we were able to look inside a human body in 3 dimensions. And that's changed oncology in many ways, but massive changes in precision for external beam and brachytherapy planning and delivery. The number of practitioners exploded, and there was a hugely increased likelihood that a nurse might find themselves working in a facility that offered radiation therapy. Concurrent and adjuvant systemic therapies have evolved and also massively increased during this time period, and adjuvant and neoadjuvant surgical protocols as well. That means the side effect profiles have constantly evolved. That means multidisciplinary care has been massively transformed, and that the need for navigation. Lately, modern treatments are also getting shorter for some diagnoses. That means a greater need for education of the patient as well as telehealth and triage. It's still going on. The most recent numbers from the NCRP showed over 1 million treatments a year, with 60% of all treatments given to people with breast, prostate, and lung cancers, 50 to 60% of all cancer patients receiving radiation therapy at some point during their cancer journey, but also 8 million interventional radiology procedures a year. And things like yttrium-90 tagged spheres for radioembolization, that's playing a growing role in radiation oncology. 13.5 million nuclear medicine procedures, some of that being using PET simulation in the department. Also, PET-LINAC is now a reality. But also 1 million of those procedures were therapeutic. That means radiopharmaceuticals, and that's playing a huge role in radiation oncology too.
Wow, that's amazing how far treatment has evolved. And as you said, the side effect profile, how important multidisciplinary team is, and also the role of nurses and how working with all of these different specialists. And as we kind of navigate that role, regardless if we're working as the triage nurse or the nurse managing symptoms, it's really a lot for nurses. So how has ONS supported nurses working in radiation oncology?
I remember as a new grad back in 98, walking onto the oncology floor, we had patients with pink labels on the chart, and that was the radiation oncology service. I hadn't heard of such a thing before. We had gynae LDR in one room and radioactive iodine in another. I had no idea why some of the rooms the walls were so much thicker than others. I'd gone through nursing school and hospital orientation and unit orientation without ever hearing of these therapies. At the time, both the management and the union had no interest in specialist nurses, and there really weren't any books that were targeting the role, and it was very isolating and frightening. I was very glad to find ONS when I moved to the U.S. For right now, the Oncology Nursing Society Manual for Radiation Oncology Nursing Practice and Education, it's in its 5th edition. I hear a 6th is underway. There's nothing else like it. Most books are very much geared towards other professions. And the huddle cards are starting to go and show more radiation content. The radiation oncology track at Congress, I'm proud to have spoken there twice. I'm glad that's going. Podcasts with radiation content are increasing in number. Love seeing that. ONS Voice, I've contributed a few articles over the years because of issues I experienced in my department, and ONS Voice editors were very receptive, and it was a very positive experience, and I encourage others to get involved with that resource and contribute pieces. The radiation oncology certificate was recently updated. The OCN core curriculum is being updated. And I hear that there is a serious effort to create a certification. I welcome that. I think at this point it's still important to utilize resources from radiation oncology and radiology as the nursing education in this field has been limited. There have been studies showing that nurses in the radiation oncology department have said they received no content on radiation oncology going through training and really very little on oncology in general. So there have been some criticisms, but I appreciate that an honest effort is being made to address them, and I think the future is looking very bright.
Well, thank you for all of your work that you've done helping educate other oncology nurses working in radiation oncology. It's such a subspecialty area and very important, especially in the sense that sometimes patients are seen every day. So you really build that relationship with individuals and their families throughout treatment. So thank you for all that you're doing and have done in radiation oncology. For our final question, what do you see as the next frontier in radiation oncology and in the role of oncology nurses working in radiation oncology?
We might be. This is a little bit more than just pandering to the audience, but there was a recent Red Journal article that noticed the most impactful strategy to reduce radiation oncologist burnout was optimizing multidisciplinary staffing and also allowing for more time for research, greater support in the department. And I've seen that firsthand. The one radiation oncologist was supposed to be treating patients in 3 different locations, didn't have an NP or any APP that was backing him up, but he wasn't on site, and being pulled in 3 directions at once was very difficult. Another radiation oncologist, I really regret this, she ended up needing to take a 3-month leave from work, and I think that's so sad. It's a very rewarding field to see just how difficult it has been for some. They need the help. Navigation and coordination of care is more essential. The Commission on Cancer has made timely postoperative radiation therapy and head and neck one of their standards. That means a lot more focus on navigation. Shorter treatments mean more triage. We need to work more on that. Infusion therapies and surgical care, this is core nursing. And we've got decades of hard-won knowledge that can benefit these initiatives. Certainly, any successful radiopharmaceutical program is going to need that infusion therapy knowledge. And I'm seeing increasingly nurses talk about pacemaker management, continuous glucose monitor, more of the brachytherapy, which involves pre- and intra-op and post-op care, post-anesthesia care. Concurrent therapies and multidisciplinary therapies are going to continue and grow more so. So survivorship in the 1970s, around 50% of patients lived 5 years or more. And today that's 70%. We have millions of people that have continue to live with radiation sequelae, and that's going to be a growing need that's not going away. We need more help with that, and that doesn't just go and speak to the nurses in the radiation oncology department, but really pretty well every aspect of nursing is going to be affected. There's tens of millions of survivors in the country right now, and if we're talking 50 to 60% of them treated with radiation, it's in the millions. Research is becoming an increasing focus of radiation oncology, and oftentimes the research coordinator is a nurse. We're treating people that are far sicker than we used to. Most of the nurses I've worked with have had their ACLS and PALS. Maybe one of the biggest challenges I see in the near future, there have been some discussions about direct supervision and what does that mean for the physicians. So you've got, again, that one gentleman that had to go and work in 3 different sites at once. There were requirements for him to be physically present at a machine for certain types of therapy. That just wasn't possible. I think we need to leave them to make these decisions. That's their world. But one way or the other, whatever they decide, if there can be more remote care while nurse and APPs are doing more of the direct boots on the ground, or if they're going to insist that it needs to be the physician on site, either way, that's going to have a massive influence on our role. New technologies are going to continue to be developed. In some cases, our role might not look directly applicable. For example, MR-Linac and adaptive planning. That means the patient's on the table longer, maybe needing pain medicine for longer. That means potentially having a rapid response situation in the MR suite, which was not something that was covered in my core nursing training. The adaptive planning right now can pull radiation oncologists out of clinic for hours, and the rest of the clinic work still needs to continue. So not directly our role, but definitely something that goes and affects our role.
Absolutely. I think the future of radiation oncology nursing is going to continue to grow, as you stated, by your great thoughts on the future and just your experiences. So definitely something we should advocate for within our cancer centers. So thank you so much, John. We probably could have had a whole other hour talking about radiation oncology, but definitely appreciate you spending time with us today to share with us your knowledge and experience. Thank you so much.
I'm very grateful to ONS and for everything that it's given me over the years, and congratulations on 50 years. And thanks for giving me the opportunity to speak.
Scarlott Mueller began as a bedside oncology nurse before managing Duke University Medical Center's first dedicated oncology clinical trials unit. She later developed the first cancer program at HCA Florida, North Florida Hospital, where she served as vice president and chief nursing officer for over 20 years. She currently serves as secretary of the American Cancer Society Cancer Action Network Board and is a member of the Oncology Nursing Foundation Capital Campaign Cabinet. Thank you so much for joining us today, Scarlott.
My pleasure, Darcy. This is certainly a full circle moment for me, as I was hired for my first oncology nursing position by Brenda Nevijan. She had such a positive impact on my career, and I know that of many others. And now here we are, almost 50 years later. Very exciting.
Yeah. Oh, that's great. I love that. Thank you so much for sharing that with us. And I agree, Brenda has impacted many of us in our career paths. Chemotherapy has long been considered the backbone of cancer treatment. Over the past 5 decades, we've seen significant changes in how it's administered and its role alongside other therapies. Scarlott, if you could, please share with us your experiences mixing chemotherapy at the point of care. What key milestones have shaped the nurse's role in chemotherapy administration and in supporting patients through treatment?
Certainly, Darcy. My first experience mixing and administering chemo began in 1978 on that oncology adult clinical trials unit, as you mentioned, which included patients undergoing bone marrow transplantation. We had a primary nursing model with an all-RN staff performing venipunctures for blood work as well as IV insertion. And, in hindsight, it was a bit of a utopian situation. We mixed our chemo in a very small medication room on the unit under a horizontal laminar flow hood, which we later discovered should have been a vertical laminar flow hood. Initially, we did not use any personal protective equipment. I remember mixing drugs like bleomycin and getting a little spray back from the vial onto my face. And, to this day, I still have a few facial blemishes from that. For several years, we never thought of these as hazardous drugs or that we were at risk from exposure. I don't think we were naive. I think that the data documenting the risk was just severely lagging. In answer to the second part of your question, there have been many changes since the 70s that have shaped the nurse's role in administering chemo and supporting patients. I'll touch on just a few key examples. The major change early on was a transition from that of nurses mixing chemo to that of pharmacists. Regulatory agencies like NIOSH and OSHA defined chemotherapy as hazardous drugs, and professional organizations became involved, leading to the publication of the joint ASCO and ONS standards of safe handling. If you haven't heard the podcast on safe handling by Dr. Marty Polovich, I highly recommend it. Thankfully, we've had many innovations in medical equipment and devices that have added safety measures for chemo administration. For example, click locks on IV tubing have minimized the risk of disconnection that caused unnecessary spills and loss of drug dose. Central and peripherally inserted vascular access devices have reduced extravasation risk and unnecessary venipunctures. And the development of patient-controlled analgesia pumps made nursing more efficient and gave patients a sense of empowerment to manage their pain symptoms. The setting for chemotherapy administration moved from mostly academic settings to community-based cancer programs within hospitals, allowing for closer-to-home treatment. Sometimes chemo nurses had to administer chemo to patients on several inpatient units, including even critical care areas. The healthcare reimbursement evolution to managed care led to more chemotherapy being delivered in the outpatient setting and eventually, as we know, into the home. This meant that outpatient chemo nurses had to assess and monitor patients very closely between visits and document side effects and symptoms. And since sicker patients were now the ones being admitted, inpatient nurses had to hone their assessment and monitoring skills, as well as knowledge and skills in symptom management. Improved and timely communication with physicians and the entire support team became paramount. And finally, advances in technology have enabled computerized protocols and documentation, reducing chemo errors from illegible orders and progress notes. Smartphones have improved timely communication among healthcare team members and with patients and families. Virtual communication and the escalation of telemedicine during the pandemic have contributed to faster interventions for oncologic emergencies and symptom management of chemotherapy treatment. These are just a few examples, Darcy, but clearly we've come a long way since the 70s.
Absolutely. And I just, thank you and all of the nurses that worked during that time in the beginnings of cancer care administration. What pioneers you all were, setting the stage for the next steps in administration of chemotherapy. Which leads me to our next question. In what ways did practice change when the ONS chemotherapy and biotherapy guidelines were published?
Well, first of all, I think that having these new guidelines was like finding the Holy Grail. They were outstanding, and they were initially and still are in subsequent editions a major resource for cancer nurses in all patient care settings. The advent of biotherapy was somewhat overwhelming, I think, initially for all of us. Caring for patients receiving hematopoietic growth factors with chemo and the emergence of drugs like interferon and interleukin-2 required a much more in-depth understanding of the immune system and their interplay with each other. Nurses had to sharpen their assessment and monitoring skills to adequately manage the complexities of potential toxicities, such as cytokine release syndrome, and side effects like fatigue or severe skin reactions. Providing emotional support along the cancer continuum became even more important in day-to-day nursing practice. Using the guidelines helped to educate nurses in such a comprehensive manner. They could then educate and support patients and families more easily to make informed decisions about their treatment initiation, continuation or discontinuation, and to report symptoms and side effects. Having accurate information about these treatment options also helped patients when considering the financial implications of treatment. Nurses administering these therapies often strengthen their collaboration with advanced practice nurses, some of whom developed subspecialty expertise in these areas. We've long been known for our role in coordinating patient care. These guidelines gave us a frame of reference to share information with colleagues on the multidisciplinary team. For example, helping physical or occupational therapists understand the reasons behind extreme fatigue and how this affected cancer rehabilitation. Having access to these guidelines, as well as the oncoming plethora of opportunities for conferences and online networking, certainly via the All ONS Member Community Digest, has enhanced our practice. These resources allowed for focused dialogue, many times resulting in timely problem solving for chemo and biotherapy administration issues and symptom management. And certainly the recent edition of the guidelines is invaluable to our practice as we continue to move toward a more patient-centric model.
What a game changer these were to have available. And as you articulated so well, just to share that evidence with our multidisciplinary colleagues so they know the importance of the why behind we're doing things and recommendations we have for our patients. So fantastic. Thank you so very much. So we've talked about the past. So time to look in your crystal ball, so to speak, Scarlett. Can you share with us what emerging trends do you believe we will see in chemotherapy administration that will shape the next chapter for oncology nurses?
Well, first of all, I wish I had that crystal ball. I don't think that chemotherapy and its benefit in combination with other treatment modalities is going away anytime soon. That said, I really don't envision a proliferation of new drugs now that immunotherapy has become such a significant game changer. We're already beginning to see precision medicine targeting specific therapy and certainly the contribution of molecular testing, which I think will only increase. The digital virtual world, including telemedicine, as I said before, is here to stay. I think it will continue to enable and improve timeliness of reporting and monitoring of treatment side effects and the implementation of symptom management techniques. Mobile apps are being developed to further enhance communication and tracking the response to treatment. Further innovations of AI and effects on chemotherapy administration, as well as cancer treatment and just care in general, are yet to be determined, but are certainly moving forward. As treatment in the home becomes more of the norm, I think we'll see even more educational focus on safe handling for patients and families, especially the disposal of used equipment and unused oral chemotherapy. And lastly, the current landscape of cancer research for prevention and early detection and treatment breakthroughs face significant budget cuts, as we know, at the federal level that may slow or halt our progress. This comes just as we are on the verge of cancer vaccines and their potential role in treatment and survivorship, as well as recent cures that we've experienced for diseases like melanoma. The impact this may have on the largest aging population in our country's history could be catastrophic. I urge each of us individually and collectively to continue to be the voice of our patients. Using our experiences through the cancer lens, we can bring awareness and advocate for the imperative need for more funding for research and equity and access to care and treatment. Thank you, Darcy, for this opportunity to share my thoughts and observations from over these 50 years.
Wow. Well, thank you, Scarlett. I mean, that was fantastic overview, and your crystal ball is pretty in touch, I would say, especially with what we're seeing happen in real time. And as nurses, we are patient advocates. That's one thing we can bring to everyone is our voice and share our patients' stories with those that are making decisions at the federal level. So thank you very much. We appreciate your taking the time to share your experiences and expertise with all of us. Thank you again.
My pleasure. Thank you.
Mary Anderson, an oncology nurse for 36 years, has championed many advancements in cancer care throughout her career. In her commitment to improving adherence and safety for patients on oral oncolytics, she has been a major stakeholder in developing key interprofessional processes in this area. Now, Senior Manager of Nursing Initiatives at NCODA, she empowers oncology nurses with the knowledge and tools to navigate complex cancer care with confidence. Thank you for joining us today, Mary.
Hello, Darcy. Thank you for having me. I'm really honored to be a part of this special 50th anniversary podcast with Oncology Nursing Society.
We are too. The introduction of oral oncolytics has been a game changer in cancer treatment, offering patients more convenience, but also introducing more challenges around patient education for safe handling and managing adherence to regimens. Mary, How has the role of the oncology nurse expanded in the management of oral therapies, particularly the role of an oral oncology nurse navigator? What does a, quote, typical day entail?
Well, Darcy, you have me. First of all, that's a loaded question. And I could literally talk for hours on that. So first, let's talk about how it has changed over the years, just a little bit, and how oral oncolytics and taking care of our patients has changed as it was 20 years ago. Before, it was a very reactive process where, we know that for our patients taking oral anti-cancer medications, there are several advantages, but there's also a lot of burden and expectations that we put on our patients to obtain their medication, to navigate a complex healthcare system to even acquire their medication, and then to, once they get their medication, to be able to stay on their medication and remain adherent. So how has that evolved for nurses, right? So before, we were literally handing our prescriptions, handwritten prescriptions, our patients' prescriptions, and they were taking those to their local pharmacy. And we were asking our patients and telling our patients, call us when you get your drug. So not very fair to our patients. And so that role of nursing has really evolved in how we truly care for our patients now, from the entire treatment trajectory, from treatment ordering and planning through that journey to acquire their medication and to support our patients throughout their therapy. So now to get back to your question about the oral oncolytic nurse navigator, nurses are very critical thinkers and we're planners. And so what we have done is we have taken that reactive process where we have put that burden on our patients and really made it a proactive process where we're proactively educating our patients up front on those expectations that is required to obtain their medication and to stay on it and to remain safe. We are addressing adherence barriers early on. We're identifying those barriers and helping mitigate those barriers. And one of the key things that an oral oncolytic nurse navigator does is to truly track that prescription with the patient and that interprofessional collaboration that has to occur throughout the entire treatment regimen. So we're constantly in communication with pharmacists, our providers, the actual specialty dispensing pharmacy, the financial counselors that are involved in helping the patient obtain their medication. And then along the lines with that, we are communicating with our patient throughout the process and throughout that journey to identify any gaps or breakdowns in the process and to keep those patients from falling through the cracks. So once our patients receive their medication, we're tracking their adherence and also their toxicity levels. So we have to plan our outreach for our patients based on our prior assessments, right? So we're individualizing our plans for our patients based on the treatment complexity, what social determinants of health that we have already identified. And we are, once again, collaborating with the entire interprofessional care team to make sure that our patients are coming in for their laboratory monitoring when that's scheduled, that they are keeping all their appointments, that they're getting their refills on time. So the day-to-day role of an oral oncolytic nurse navigator is a mix of several things where we are constantly communicating and collaborating and keeping things moving forward in the process with our patients.
Great. And I think you really captured that role perfectly in the sense that we need to be communicating with our patients constantly, as well as the interdisciplinary team, which leads us to our next question about the resources that ONS has developed to help oncology nurses care for our patients and help streamline that communication between not only the nurse and the patient, but also members of the interdisciplinary team. Can you tell us a little bit more about the resources that are available that nurses can access to help our patients?
So the Oncology Nursing Society has really supported nurses caring for patients taking oral anti-cancer medications early on. ONS has a pretty extensive oral anti-cancer medication learning library. And within this library, it contains lists of periodicals and journal articles, podcasts and videos. And it also has the very popular oral anti-cancer medication toolkit. Now, most recently, which we have just launched within the past few weeks, ONS has collaborated with NCODA on the Oral Anti-Cancer Medication Care Compass. So this is a collaborative effort that pharmacists and nurses, where we developed a collection of resources that benefit the entire oncology care team. And one of the tools that's within these resources is a tool that helps practices actually analyze their workflow for caring for patients taking oral anti-cancer medications. And it helps them analyze their workflow and also develop a workflow with the resources that they have within their practice setting. And some other tools within the OAM Care Compass is a patient education resource checklist and a CTCAE grading guide, which also has an interactive activity to test the knowledge. So one other thing that I actually forgot before I started going into our OAM Care Compass are the oral chemo education sheets, which are also another collaborative resource that ONS did within CODA and 2 other organizations. And the oral chemo ed sheets are very popular patient education sheets where they actually provide that essential groundwork for our patients to understand the medication, how to self-administer the medications, what side effects to look for, and how to manage your side effects. So ONS, like I said, they have their learning library, but also these collaborative efforts within CODA in the OAM Care Compass, which is on both of our websites. It's on the ONS website and the NCODA website, and the oral chemo ed sheets, which are constantly growing and evolving to the IB education sheets.
That's great. I love it. I love seeing how responsive ONS has been to oncology nurses caring for patients receiving oral oncolytics, and also the importance of collaboration between organizations as well as the multidisciplinary team. We're not an island, are we? We all have to work together to provide the highest quality care for our patients. And a couple things you mentioned that I hope our listeners will access is looking at the checklist and also the CTCAE guidelines. And I think also really important as this technology and this treatment grows is analyzing the workflow in your practice. So kudos to everybody involved in that development. So I think it's wonderful. Thank you for sharing that with us, Mary. Now, we talked a lot about the history and what we've done presently to help our colleagues care for patients receiving oral oncolytics. So for our final question, it's time to pull out your crystal ball, if you could, a little bit. And if you could tell us, what do you see as the future of oral oncolytics and the role of the oncology nurse?
Yeah, so as the increasing number of these actionable mutations continue to grow, so will the number of oral anti-cancer medications that patients are going to be taking. And we're already seeing that there's multiple combination regimens and complex schedules that the patients have to take. So this role, the oral oncolytic nurse and the nursing role, like you said, it cannot be owned by one individual or discipline, right? So it's not a pharmacist. The pharmacists aren't owning this. The nurses are not owning this, right? It takes a village. So my advice for nurses, especially if you're an infusion nurse or if you're working in the clinic and your patient is taking an oral anti-cancer medication, don't shy away from it and don't shy away from those conversations, right? While the names and the indications and administration instructions can be overwhelming, we can all support our patients by having like an open-ended conversation with our patient. And this is really my vision. This is where I really want to see for all nurses to have the confidence to open the conversation with their patients. Just for a simple discussion, I see that you're taking a medication to treat your cancer. How are you taking it? Are you having any difficulty with your refills? Are you having any difficulties paying for your medication, right? Just having an open conversation and then to identify any problems that the patient might be having and then going out and reaching out to your navigator or your pharmacist to get those resources that the patient needs. So it's also really my hope as we continue to see the rise in oral anti-cancer medications that as nurses that we continue to really elevate ourselves as integral members of the interprofessional care team, like you said, and that we really continue to play those pivotal roles in developing those interprofessional workflows that are so important to improve our patients' outcomes.
That's great. That's a perfect way to sum up and look at the future of the important role of the oncology nurse caring for patients receiving oral anti-cancer therapies. Thank you so much, Mary, for taking the time to join us and share your experiences and expertise.
Thank you, Darcy. It was my pleasure and a lot of fun. I appreciate y'all having me.
Kathleen Shannon-Dorcy has worked in cellular transplant since 1985, beginning in a pediatric unit before transitioning to clinical trial coordination for hematologic malignancies in 1990. Now, as the Director of Scholarship, Leadership, and Ethics at Fred Hutchinson Cancer Center, she brings 38 years of experience, all at Fred Hutch, which coincidentally also celebrates its 50th anniversary this year. Thank you for joining us today, Kathleen.
Thank you so much for inviting me. It's a privilege to be with the Oncology Nursing Society and celebrating 50 years of oncology excellence.
Stem cell transplantation and cellular therapies have evolved dramatically over the past 5 decades. CAR T-cell therapies, T-cell depletion, lower intensity conditioning regimens, and increased precision in the selection of donors have revolutionized the treatment landscape for patients. Kathleen, as Fred Hutch was one of the pioneers in establishing cell transplant programs, take us through the early days and how oncology nurses were involved in the development and success of these programs.
It is very exciting to see the integral collaboration between nursing, the scientists, the physicians, nutrition, social work. It was one of the first clinical areas where science and the true state-of-the-art engagement of innovation, nurses had to find new ways. At that point in time when we first began, patients were in kind of bubbles in LAF rooms where patients, and they were almost all little children because we were working mostly with young people. And those little kids would be in these LAF rooms and their parents had to gown up to spend time and hold them and be close. Nurses had to gown up. We spent time doing incredibly complex procedures in the room, all in protective clothing to protect the immune system. And then also, as we went forward, we found ways that, in fact, protecting the immune system and really suppressing it somewhat with like cyclosporin and drugs like that went on to improve and protect against graft rejection. There was a balance in how we did that. One of the important things that happened in oncology nursing was that nurses began to develop policies, procedures, and state-of-the-science act that could really inform and educate. So we became a part of national and international groups of people who came and worked with us and learned how to do transplant. And our physicians that had been here at UW, University of Washington, went across the world, across the country, taking transplant science. And then our nurses would also go to other sites and work. On the day that Dr. Thomas was a Nobel laureate, and he began his work in the 50s and in the early 70s when the first transplants happened. But if you fast forward into when he was awarded the Nobel Prize with a physician scientist in France, he got up at 2 a.m. when he and his wife got the call and came to see the nurses on night shift to thank them for what their contributions were to the Nobel Prize and into saving the lives of so many people. When he first began, there were essentially 1% to 2% survival with chemo. And then if you fast forward to now, the bone marrow transplant and cellular therapy for acute lymphocytic leukemia has a survival rate of around 98%. This is an incredible gift of lives and families kept together with the science of transplant and immunotherapy. I think it's so exciting to see that nurses stood there in the very frontier lines of pioneering of how we could care best for people and learned how to live in the grace of hoping for cures, but also walking the journey of those who didn't make it and celebrating the lives of those we cared for.
Wow, that's just beautiful and amazing all at the same time. Thank you so much. But with all new treatments, there's challenges, but also opportunities, as you mentioned, for oncology nurses to make a difference, especially surrounding side effect management. You touched on this a bit, but I'm wondering if you can go into just a little bit more detail for our listeners. How has oncology nursing care evolved and adapted to meet the unique challenges of CAR T and other cellular therapies? And how has ONS supported nurses in caring for these individuals?
Thank you, Darcy, for that question, because ONS has been at the front line. So from bone marrow transplant and the different ways we learned how to really balance T-cell activation and protecting people from graft versus host disease or from secondary malignancy from the radiation we gave to treat the leukemia before we gave cells to kind of re-energize the immune system. We knew that cellular therapy was an incredible science. Before immunotherapy was even totally finalized, Dr. Thomas would have all the fellows come to his house for a picnic in July as they began the new academic year of being fellows in oncology. And one of them said to Dr. Thomas, "So what do you think is there anything left to discover? And Dr. Thomas put his glasses down on his nose and looked him straight in the eye. There is so much left to be discovered. And then as immunotherapy comes into the picture, we start to learn about CRS, the cellular reactive syndrome, that all of a sudden we had no concept that this was a deadly consequence. ONS was on the front lines, convening people, bringing people across the country together so we could speak to this, investigate it, work with science, and find ways that we could intervene, how we could look for signs of it early on with handwriting testing. Because ONS works also with the tandem meeting, the International Cellular Therapy Group, we were able to work with nursing, pharmacy, scientists, and bring all of these science together in a continuing model of how do we understand and create ways to this wonderful CAR T-cell therapy that can be designed specifically for the disease of the individual, and yet see these incredible toxicities. How do we balance those? And how do we continue to know we don't know yet? And how do we be open to what is yet to be revealed in these? Bringing scientific new modalities forward means that all of us have to collaborate and note the changes so that we can continue to build out how we can best care for challenges yet unknown.
That's absolutely true. Oncology nurses, we're always on the front lines. We see the patients most frequently. So it's no surprise that Dr. Thomas was so thankful to the oncology nurses that were caring for the patients early on and up until as long as he has been there. So that's great to hear. So one last question, Kathleen, just time to look through your crystal ball for a moment. As cellular therapies continue to advance, what do you see as the biggest opportunities and challenges, perhaps, in integrating these treatments into standard cancer care?
Well, Darcy, sadly, at this very moment in time, on March 11th, 2025, one of the hardest things that I think we're facing is the reality that we must be able to stand firm that science matters and that understanding the immune system, vaccine, international collaborations have to happen. So I see some of what we have politically happening as the most important way that we must balance inquiry and respect for one another to really be open to what can yet be discovered and hold the fact that with illness, one of the best things we need to know is that working with the body's own ability, cellular therapies are going to bring new ways of mitigating illness, but also perhaps things we've not yet understood. And how do we deal also with childhood survivors? How do we help people who have been treated, who have gaps in their CVs or resumes because they were in treatment for 4 years? And how do we allow for illness to be not a barrier to fully being employable and to being successful, but once again, successful young adults? I think the biggest challenge we all face is how do we not become silenced? How do we not become complacent? And how do we hold somewhat the suffering that comes with illnesses like cancer, the suffering for families, for people who will never get to their 8th grade graduation, for grandmothers who want to hold the next great-grandchild who's being born? How do we stand in company of that with the still hope that there is a chance for increased survival, but also that we are there in the journey to be part of the consolation of loss of those who've been so severely affected by illness, solid tumor, hematologic malignancy? How do we hold the fact that a life, a cherished life, is what we are working with in the context of the bigger community?
That was beautiful and amazing, Kathleen. What a perfect way to end this episode of our podcast. This technology, I just can't wait to see what the future holds with this innovation. And certainly, as you said throughout our podcast, balancing this with human lives that are dealing with this and those whose lives we'll celebrate continuously, who were also part of the journey that may not be with us anymore. So I'd just like to take this opportunity to thank each of the nurses who joined us today for their leadership and for sharing such powerful insights. It's clear that while cancer treatments have advanced significantly over the past 50 years, oncology nurses have been at the forefront of these advances, ensuring that patients receive high quality as well as evidence-based care always. Thank you so much.
Thank you.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.